Hello, and welcome back to a brand new episode of Clotcast and a brand new series titled Heart and Blood. This series will be focused on the many areas of overlap between cardiology and hematology, and there's several of them, primarily as it relates to hemostasis and thrombosis, or bleeding and clotting, in the setting of patients who require cardiac interventions. I am thrilled, and it brings me immense pleasure to introduce my dear friend and long-term colleague, Dr. Nashwa Abdulsalam. Nashwa is a board-certified cardiac electrophysiologist at Peace Health Southwest Medical Center. Hello.
Hi, I am so excited to be here. Yazan and I are old colleagues, and I'm really excited to meet up with you again doing this.
Thank you for joining. So Nashwa and I did our residency together in internal medicine at Rochester General Hospital. Shout out to RGH.
10 years
And it,
ago. Can you
10
believe
years
it? Time
ago.
flies.
It really does. All right, well, let's get to it. So today's episode is going to be focused on AFib and bleeding disorders.
And the reason we picked this topic specifically is because AFib is the most common arrhythmia worldwide, and the prevalence is only expected to increase with our aging population.
Absolutely. And thanks for pointing that out because, especially in patients with bleeding disorders, in particular hemophilia, the life expectancy of patients with hemophilia has tremendously improved over the past few decades, thankfully. However, that also means that we have now an aging population with bleeding disorders who are more likely to have comorbidities such as different cardiac disease, valve problems, as well as arrhythmias such as AFib.
In addition, the prevalence of AFib in patients with bleeding disorders is similar to the general population, and so we are expected to see more of those patients in the future. And so today we're going to be discussing the specific challenges that we encounter in managing those patients, specifically in the perioperative period.
Having a bleeding disorder had been considered a contraindication for antithrombotic management or anticoagulants, which is often required for various cardiac interventions. And so determining the suitability or the eligibility for undergoing these procedures is heavily dependent historically on what the bleeding risk and what the clotting risk is, and that allows us to create a treatment plan that ensures safety of these procedures.
Yeah, and it's important to mention that we rely heavily on the CHA2DS scoring system to determine which of those patients need long-term anticoagulation. But we have not incorporated those patients in the scoring system. And so does that really apply to them? And it's postulated that the CHA2DS scoring system really overestimates the stroke risk in those patients, while the Hasbled scoring system underestimates their bleeding risk. And this
Right,
becomes a
right.
challenge.
It really is. And I want to point out that there really is a paucity of data when it comes to the management of cardiac complications and comorbidities and procedures in patients with bleeding disorders. So this makes it a lot harder for us to know what to do. We don't have any good, strong data or large data. And so it's very dependent on the clinical evaluation. And what makes this harder is that bleeding disorders are very broad and very variable. There's many different kinds of bleeding disorders, different pathophysiologies, different severities, and different symptoms and clinical presentations.
So from what I'm hearing, is there a unified way through which we can treat those patients, or is it usually a tailored therapy?
That's a great question. I believe strongly that treatment should be very individualized and tailored to the patient's own risk factors, the type of bleeding disorder, the severity of that bleeding disorder, and the availability and feasibility of therapy. There's many kinds of different bleeding disorders that affect different pathways of hemostasis. So primary hemostatic defects, including von Willebrand disease and platelet function disorder, and then secondary hemostasis with coagulation factor deficiencies, such as hemophilia A and hemophilia B, and so on. So these are the hereditary bleeding disorders. There's also acquired bleeding disorders that could be autoimmune in nature, for example. And all of the above can have different levels of severity, different interventions, and different symptoms. So it's very hard to have a kind of cookie cutter, one size fits all, even for a specific disorder. We try to do that sometimes. So for example, for hemophilia A, we sometimes create algorithms based on the factor level that we can replete. But I do ultimately think that even for a specific bleeding disorder with available data, it should ultimately be tailored to the individual.
Well, that's very insightful and very interesting, which even, emphasizes more the importance of collaboration when it comes to management of
Absolutely.
those patients. The one important modality that I want to talk about is catheter ablation for AFib, because per our most recent 2023 AFib guidelines, catheter ablation has a class 1 recommendation for management of AFib. And there has been huge advancements in, AFib ablation, and now with the emergence of pulse field ablation and how the procedure has become an outpatient basis, and even now we're looking into it being an ambulatory procedure. And so it's become a very common and standard of care for management for AFib. And this procedure, however, comes with the need for high doses of heparin during the procedure, and patients need to be on uninterrupted anticoagulation for at least 3 months after. And so the question that comes is this a feasible management strategies for patients with bleeding disorders? And if so, what measures can we take to make sure that they get through this procedure safely?
Yeah, that's a great thing to discuss, and I'm glad we're talking about that today. Because in my practice, I do think of this as three phases. So there's the pre-operative phase. So this is when we're evaluating the patient and creating a treatment plan, and also determining their diagnosis, the severity of the disorder, and so on, the feasibility of factor replacement, ensuring availability of treatments, and so on. And then the intraoperative phase, so making sure that the procedure itself goes safely with minimal bleeding risks or complications. And then the post-op phase, or the long-term phase, where patients who require cardiac interventions often will need antithrombotic therapy for a certain period of time. And I guess, it'd be great for us to kind of discuss each of these individually and our approaches for them. And so I guess, one thing we could go over first is the preoperative phase.
Well, let me interrupt you for a second and ask a very important
Sure.
question, because we're a lot of times we see patients, we want to get them their ablation, we want to do it, we want to treat the rhythm. But the question is,
Mm-hmm.
how early before the procedure are we supposed to refer those patients to hematology, or discuss their case with the hematologist? Like, how much time do you need to make sure that patient is optimized, and what are the steps that you actually take to optimize those patients for the procedure?
And sometimes I may have to answer your question with a question to you, which is, how much time can you give us? Ultimately, if it's an urgent procedure, we will make sure that the patient is evaluated in a timely fashion. For example, in my clinic, I'll double book or triple book a patient, or squeeze them in early to make sure everything is necessary. However, we ideally, in an ideal scenario, would like maybe a 1 month heads up at least. That allows us to first evaluate the patient, get any necessary blood work to ensure the accuracy of the diagnosis and understand the severity, and then also prepare for the therapeutics. Factor products are very expensive. A lot of insurance and logistics have to be factored in, and so on. Factored in, no pun intended. So there's a lot of preparation that goes into this. And so ideally, we do want like a 1 month at least heads up if it's if possible. Would you say that most of the time interventions are elective in EP?
That's actually very reassuring, because usually, how common AFib ablation has become, the wait period is usually a month, 2 or 3 to get the ablation, and it's usually an elective procedure. So we really try to make sure the patient is optimized, whether they have CHF, make sure they don't have any exacerbation, whether they need a colonoscopy, they need a tooth extract, they need something. We make sure that they get all of this done before, that they're optimized, that they have some sort of infection that's treated. So it's really an elective procedure. I think the main challenge
Yeah,
would be,
that's
if they
great.
have not seen hematology and we're suspecting a bleeding disorder, how fast can we get them, after being referred, which is usually a challenge
Right.
to see a specialist.
Right. First of all, I'm glad to hear that most of the time it's elective, because that gives us ample time to do, necessary evaluation. A lot of times I'll get a call from a surgeon and they'll say, "Oh, the patient is in the OR and they're just bleeding heavily. What do I do?" So,
We try to
so
be
we
better
need
than
time,
that.
and So, ultimately, we're prepared for whatever scenario.
Well, what about the intraoperative management? We usually give heparin with ACT goal of 350 or more to make sure
Yeah,
they don't have a stroke during the procedure. Are there specific interventions that need to be done in the intraoperative period? And I know that per our
right.
discussion prior to, you know, this discussion, I know
Yeah.
that you guys don't like the ACT, but that's what we use during the procedure. But are there any specific
It's not that we don't
measures?
like them, we just don't use them.
Um,
Yeah, I mean that's a great question. To comment about the ACTs. So in our bleeding disorder evaluation, we typically use more reliable tests in terms of coag screening, such as PTTs and PTs, and then specific factor measurements. But of course, in the on the operating table in the OR, you need something more rapid, and that's why I think ACTs are the go-tos for interventionists. So to answer your question, what the intraoperative management of patients with bleeding disorder entails from our side is correcting the hemostatic deficit. So in a patient with a coagulation factor deficiency, factor 8 for example, aka hemophilia A, we can give the missing factor and we'll create a treatment plan for the cardiologist or for the surgeon with a specific dosing, specific product name to give before the procedure, specific time and so on. So it'll be a very clear plan as well as the follow-up measurements and the follow-up or duration of required treatment. And of course, this is dependent on the disorder. So what the surgeon or cardiologist would expect is to see a very detailed treatment plan from the hematologist. And if you don't see one, please call and page the hematologist to make sure that this is set in place.
Well, and that brings a very interesting point, which is those patients then are better served in a big hemophilia center where you have all these services because not every hospital is able to provide all these services.
So we have dedicated or designated hemophilia treatment centers that specialize in bleeding disorders. And it's very important that a patient with a known bleeding disorder is established there because we usually have the necessary expertise in terms of physicians, nursing, physical therapy, pharmacists, and the ability to get the necessary products, laboratory monitoring, and so on. So that's quite important to also establish whenever possible ahead of time.
So now we come to the post-operative period. So those patients, like post-AFib ablation, need to be in uninterrupted anticoagulation for at least 3 months. And that's why if they need any kind of surgeries, intervention, it's either they wait until after the 3 months or they have to get it done before because we cannot interrupt anticoagulation. The stroke risk is highest at that point, and so we need to ensure that they're not bleeding and that there wouldn't be a point where we do have to interrupt their anticoagulation. And so, which brings me to my
Absolutely.
question, which is what do we need to do for those patients during that period? How are they monitored to make sure that they're not
Yeah.
bleeding?
Yeah, that's a great question. And that's a common challenge that we're encountering more and more often. And it's a very nuanced and collaborative thing. So, it requires a multidisciplinary approach between the hematologist and the cardiologist to find ways to mitigate the risk of both thrombosis and bleeding. So on the thrombosis side, usually, the cardiologist will counsel us on what is the expected risk of clotting with or without anticoagulants, what is the necessary duration of anticoagulation, and what is our capability of shortening the necessary treatment of antithrombotic management, and as well as the possibility of avoiding anticoagulants and using antiplatelets instead. So that's in the thrombosis side of things. And then in terms of managing the bleeding disorder, that's where we as hematologists will try to find ways to make sure that the hemostatic deficit is corrected throughout the necessary duration of antithrombotic management. So, for example, if a patient absolutely requires 3 months of anticoagulants, then we would have to correct the deficit for that duration of time. So, for example, if it's a hemophilia A patient, we can correct the factor 8 level for that duration of time. And we monitor it, and then with repeat treatment, we're able to keep them steady for that duration. So that's one specific example. It could be a different disease, different thing that's being monitored. But in short, we want to try to give them as normal of a hemostatic profile as possible as compared to a patient who does not have a bleeding disorder to minimize bleeding risk during antithrombotic management.
So you mentioned antiplatelets. Our guidelines now do not incorporate aspirin as a way for management of stroke risk with AFib, which brings me to the next topic, which is left atrial appendage occlusion devices, which have become, great alternative for patients with a stroke risk and bleeding risk at the same time. They've been found to be non-inferior to anticoagulation for stroke risk prevention in patients with AFib. And so once patients
And,
get
and that's such a great development because it really is, I think, it's so important to find ways to get patients to not require anticoagulation. And, I learned something from you in terms of ablation. I, for some reason, thought that ablations also preclude the need for anticoagulation. But you mentioned to me that they don't really minimize stroke risk. Is that correct? It's just the Watchmans that do that.
So currently, the guidelines do not recommend or change the management for stroke for AFib post ablation. So this is
Right.
only dependent on the Chatsworth scoring system. We do not take into consideration whether the patient is receiving rhythm control through medications or ablation. So that
That's
does
so
not change.
interesting. Yeah, because in my mind, as a not cardiologist, it's like I've always thought of it as, all right, the arrhythmia is not happening, then they're not going to clot anymore. But I think it's a little more complicated and nuanced than that.
Yeah, and unfortunately, that's a lot of our patients' expectations that, you have to really explain that to that in the clinic that you are not going to come off anticoagulation with the ablation.
With the ablation.
Um,
Yeah.
yeah, but yeah, Watchman's
And that's
and
when you offer them the alternative, which is left atrial appendage occlusion.
yeah, and the indication for implanting a Watchman device is that they have to have a risk of bleeding, which our patient population that we're talking about would be great candidates. But the thing is, it comes with the fact that they need to still be on anticoagulation for a
Right.
short period of time until the endothelial tissue grows on the Watchman, or else they're going to thrombose and have
Right.
device related thrombus. And so
Absolutely.
currently, we either put those patients on 45 days of a DOAC, followed by dual antiplatelet therapy to complete 6 months, and then
Right.
aspirin monotherapy. Or from the get go, we put them on dual antiplatelet therapy for 6 months, followed by aspirin monotherapy. Sometimes we do
Right.
deviate from that protocol. Say, for example, someone has anaphylaxis to aspirin, but those are like the exceptions to the rule. So my first question is this a feasible treatment option for patients with bleeding disorders? And how do we manage those patients after? And is it better to put them on dual antiplatelets from the get go or a DOAC, or how do we manage those patients?
Yeah, that's a great question, and thanks for pointing that out. Actually, my colleague and I, a few years ago, published a case report on a patient with hemophilia who required a left atrial appendage occlusion. And then, when publishing that, we looked at the literature to see what other data exists. And we found a whopping 8 cases or
Oh,
something in
wow.
the entire literature of patients with hemophilia who required a Watchman. So there really is a scarcity of data on the optimal management of patients with bleeding disorders who require similar cardiac interventions. Ultimately, it was a similar approach in the data, not data, the case reports that we found similar to ours. So, ways of minimizing either the duration of antithrombotic therapy or trying to preclude the need for anticoagulants and switching to antiplatelets, and while simultaneously correcting the hemostatic deficit by factor replacement and very careful and thorough management or monitoring of the factor 8 levels in this specific scenario. And you could extrapolate that to other bleeding disorders, is that a lot of times we have something that we can monitor.
That's very interesting because from what I'm understanding is that this is a really feasible treatment option for patients with bleeding disorders, and that they can be managed afterwards so that they can be on anticoagulation safely. And sometimes we actually do implant Watchman devices before the ablation, patients with high risk of bleeding, just so that if they do have bleeding after the ablation, they at least have the Watchman to protect them. Although we don't have clear guidelines on management of patients post AFib ablation who actually have a Watchman device. Yeah, this has been very, very interesting.
It really is. And that's, I think, the challenge that we'll always have is that when data is limited, we have to rely on our best clinical judgment and evaluation in determining the optimal approach. And sometimes that requires expensive therapies, prolonged therapy, and a very kind of nuanced approach. And I do also want to briefly comment on the novel therapeutics. So, the field of bleeding disorders, and particularly hemophilia, we've made significant advancements over the past decade or so. And we now have newer therapies that are not factor replacement. So, for example, emicizumab is a monoclonal antibody that can be given once a month. So, that really makes things a lot easier. I was trying to see if with emicizumab there's any data with cardiac interventions, and again, it's case reports and so on. So there's a whole lot to learn with the novel therapeutics. And then there's hemostatic rebalancing agents. So these are drugs that target a anticoagulant part of our system. And for example, there's concizumab that just got approved a month ago for the treatment of hemophilia, which blocks TFPI, tissue factor pathway inhibitor, and so on and so forth. So there's newer therapies that work on different parts of the hemostatic pathway that may make cardiac interventions easier in the future. But there's still a whole lot to learn.
Well, that's a whole new area to explore. And by the way,
Yeah.
just as
And there's gene therapy too. I forgot to mention that. But yeah, whole lot of things.
I'm always very impressed about how you can remember the names of all these medications. They're very difficult. But well,
I can only remember the ones in my field. Believe me, I don't remember any of the antiarrhythmics or other drugs you guys use.
well, that has been very, very enjoyable to talk about and very insightful. And to wrap up some of the points, I think the most important take home point is that patients with bleeding disorders can be managed appropriately for stroke risk with AFib. They can safely get their catheter ablations. However, this requires strong collaboration between cardiology and hematology for them to be able to get those
Yes.
procedures safely. And that left atrial appendage occlusion device probably is a very good alternative for that patient population.
Absolutely. It's quite important that this is a multidisciplinary approach between the hematologist, cardiologist, and anesthetist, and also finding ways to individualize treatment. So the most important thing, in my opinion, is individualizing treatment to the patient's unique risk factors, unique bleeding risks and clotting risks, as well as the type of disease, the severity of the disease, the clinical phenotype of the disease, and the availability and feasibility of treatment. And I just want to end on a final note of kind of a patient advocacy perspective. Having a bleeding disorder should not preclude a patient from getting the care that they need and deserve. So it's important to find ways to mitigate risk to allow them to get the necessary cardiac interventions and procedures that are important for their care.
Well, thank you, Yazan, so much. This was really great, and I'm looking forward to talking about more topics that incorporate cardiac electrophysiology and hematology. And thank you.
I really enjoyed our conversation today, and thank you so much for doing this podcast with me.
Wonderful. And I'm looking forward to joining you for other conversations in the future.
Likewise. All right. Well, thank you all for listening. I hope you found this helpful. Please comment in the section below